Hello everyone, welcome to this extremely special episode on the Special Needs Children podcast. I have with us somebody who we respect a lot and look up to in a huge way because of his commitment and what he's done for the entire society, Dr. Milind Kirtane. Dr. Milind Kirtane, for all of you, is one of the most renowned and highly respected ENT surgeon practicing in Mumbai since the last 50 years. Thank you so much, Doctor, for doing this with me on the podcast. I shall try to make the introduction brief, but still we'll try to go through it. A stellar student who joined in 1965, he qualified as an ENT surgeon at the Seth GS Medical College, standing first in the University of Mumbai, and worked as professor at the prestigious Seth GS Medical College and KEM Hospital in Mumbai till 2004. He continues to work there as Professor Emeritus, associated with KEM Hospital for 60 years. He also works as a consultant at the PD Hinduja National Hospital, Breach Candy Hospital, Saifi Hospital and SRCC Children's Hospital in Mumbai. In order to train ENT surgeons in surgical skills, Dr. Kirtane conducted regular operative workshops in the field of ear surgery on an annual basis from 1976 to 2004. Which were attended by ENT surgeons from all over India. Since then, he has conducted over 200 training workshops on vertigo, otology, sinus surgery and cochlear implants in almost all the states in India and SAARC countries. He is a pioneer in endoscopic sinus surgery and has conducted annual workshops for training ENT surgeons for the last 27 years and has trained over 1200 of them. In every corner of our country, Dr. Kirtane is respected as a selfless and committed teacher. He has conducted camps in rural parts of India where over 1000 patients have been operated free of cost to restore their hearing. His largest contribution, that is outstanding, has been his work with cochlear implants. He has conducted 4000 plus cochlear implant surgeries. Apart from the thousands others, he has been instrumental in delivering through all the ENTs who have trained under him, impacting the lives of thousands of children and their families. Presently, cochlear implants to rehabilitate children born deaf is the focus of many government organizations. The central government has a DIP scheme and the RBSK for funding cochlear implants in children from the economically weaker section of society. Some state governments too are having similar schemes. This means many more patients will get cochlear implant surgery, for which many more surgeons need to be trained. Dr. Kirtane does training programs in the CI for ENT surgeons from all over the country, and he has been doing this for the last 20 years. He has a fellowship program for young surgeons to stay with him for 3 to 6 months and become proficient cochlear implant surgeons. The current fellow is his 46th student in this program. More importantly, he is committed to be their mentor. That is, he travels to their hospital and stands behind them when they do their first few surgeries. This often takes several trips, which he does on most of his weekends. He has so far mentored over 80 surgeons, 25 of them being from Mumbai itself, including the 3 municipal hospitals, both railway hospitals and several private hospitals. Besides this, he has mentored surgeons across the breadth of India. Because of his selfless efforts, children in the remotest part of India are getting treatment without the need to travel. He is now working with Samarth Assam program of the Assam government and a government hospital in West Bengal to train their doctors to do cochlear implant surgery. He runs a charitable trust himself, I Hear Foundation, to fund cochlear implants and also to train audiologists and special educators across India. To this purpose, he organizes an update annually for the past 18 years. These professionals are essential members of his cochlear implant team. For his work in spreading the specialty of ENT all over our country, he received, amongst many other awards, the late Dr. B.C. Roy Award in 2005 and of course the Padma Shri in 2014. He has been president of various national ENT associations in the country. Dr. Kirtane's tireless efforts have not only enhanced medical expertise in the field of ENT in the country, but has also had a social impact in that patients from underprivileged classes are now having access to the best of treatment in their very hometown without traveling long distances. As a matter of fact, some of his cochlear implantees have just won medals at the recent Paralympics. He is truly a make in India ENT surgeon whose entire training, except for a very short stint abroad, has been entirely in India. Doctor, I'm coming straight to the question now after that long intro. Sorry for that, although you tried to tell me to keep it as short as possible, but I couldn't. So, you are an ENT, a senior ENT surgeon in our country and in the whole world. It must have been grueling, back breaking, but extremely rewarding over these past 50 plus years. What has kept you going?
It has been grueling, as you said, because not only the training period, but once you start treating patients and get into practice, it's very long hours that you have to keep. What has kept me going? I really don't know the answer to that. There is work to be done, and you keep on doing it till it is finished. So that's about the principle with which I have worked, and whatever is there to be done just has to get done. So that's what kept me going. And the rewards that you get from the patients when they get better, I think that in itself is a motivation to keep on going, because you see the transformation in their lives, and that is so satisfying that it just wants you to keep on doing what you're doing.
Lovely. So, doctor, for all of the parents listening in, right, what are the early signs of hearing loss in children? What all can go wrong with hearing? And when should they seek a specialist?
The impact of a child born with a hearing loss is so severe, because you need that hearing to interact with the surroundings, to learn speech and language. So it's not only about development of speech and language, but the general development of the child. It's not just about hearing and speech, but it's about the brain, because that input which a child should get, the child is not getting, and therefore getting the diagnosis as early as possible is what is important. Uh, Let me answer the first part of your question. What sign should parents look for, even in a normal looking child? If you find the child doesn't get startled when there is a loud sound, that could be a telltale. I've had patients who said that something happened in the kitchen and something fell down, but the child didn't startle. Or if you find that when you call out to the child doesn't respond immediately. Delayed speech is one of the first signs, but that comes already after the age of 9 months, 1 year. Between 1 and 2, you expect the child to develop certain words. By the time child reaches 3, should be able to speak in sentences. And very often we get patients who are told, oh, don't worry, some people talk late. I don't think that should be done. The moment you have the slightest hint that the development is not taking place as it should, one of the things that you should have tested is the hearing. Uh, People are now talking about what is called newborn screening of hearing, and many hospitals do that if there has been a little problem in the pregnancy, during the labor, the child is born with some amount of hypoxia because of a difficult labor. So wherever there are at-risk babies, they tend to do the testing. But universal newborn screening means testing every child that is born. Maybe 4 to 5 out of 1,000 births will have significant hearing loss. And if you examine every child at birth, make it mandatory, then you'll be able to catch it on day 1 of life. You can start the intervention within, say, 2 to 3 months, so that the child gets access to sound and develops in a much better fashion. So I would say that just like you take your child for vaccination in a well baby clinic, even if the child is looking normal, you should do a screening test. Today we have tests which can tell you at day 1 of life that is the child hearing normally or is there some problem. And if it shows that there is some problem, then you should go and have the test done. Just because a child was born normally, looks normal, does not always guarantee that the child's hearing is normal.
Doctor, we talked about cochlear implants. So, does every child who's born deaf need the cochlear implant?
There are various grades of hearing loss. So, a child with mild to moderate hearing loss, or even some amount of severe hearing loss, may just require a hearing aid. Not that every child requires a cochlear implant. So, a hearing aid is a device that amplifies the sound so that a child or any person whose hearing capacity is a little poor will get a louder sound coming in thanks to the hearing aid and will be able to hear. Cochlear implants come into play when the hearing loss is so profound that even the most powerful hearing aid is not able to help that patient, child or adult. So, not every person or child with some hearing loss will require cochlear implants. That's a very small percentage that will require that. Many of them would get by with just properly fitted hearing aids and would be able to go through life. Of course, there are some types of hearing loss where even surgery might come into play at some point of time. Hearing aids would be given to those people who have what we call a sensory neural hearing loss, where not the eardrum but the inner part of the ear is affected, where surgery is not possible. So, those will require hearing aids, and if so profound that even hearing aids don't help, then you consider cochlear implants. So, that's a small percentage.
Doctor, can you please explain simply what is cochlear implant and what is the procedure to do this?
So, for this, I'll have to give you a very small background on how we normally hear. Sound waves are vibrations of the air. So, it's vibrating air that hits your eardrum. There's a chain of tiny bones which amplifies these vibrations and takes it to the inner ear, a part of which is called the cochlea. The job of this cochlea is to convert sound vibrations, the mechanical vibrations, into electrical signals which are fed to the nerve that starts from the cochlea, called the cochlear nerve or the auditory nerve. So, what goes from the cochlea to your brain for interpretation of the sound is electrical signals. All nerves carry electrical signals. So, when you have a deafness that is because of a problem with the cochlea, it is the capacity to convert sound vibrations into electrical signals that starts failing. To give you an example, if you remember in the olden days when we used to make trunk calls and you would have a weak connection, then you had to shout, in short, feed in more energy so that the person at the other end could hear you. So, that's what a hearing aid would do. Either you shout or the hearing aid makes it loud. But if it's a dead phone, you can shout as much as you like, the other guy is not going to hear anything at all. So, we are talking about a situation where the inner ear cochlea is failing but has some life left in it, so that if you give it a loud sound, it still manages hearing aid. If you come to a situation where the sound vibrations just cannot produce sufficient electrical signal, now you need something to replace that inner ear with a device, a computer, which will do the work that the inner ear is supposed to do. So, what you wear outside, today it's reduced to a size of a hearing aid. There was a time when the computer was as big as a room and the patient had to be plugged in. But today that thing that they wear at the back, which looks like a hearing aid, is not a hearing aid, it's a computer. The microphone picks up the sound, feeds it to the computer, and the computer does exactly what the inner ear was supposed to do. Now you have the electrical signal ready, but it's outside the body. The nerve is right inside. So just like you have a radio or a TV in your house and an antenna on the roof, and there is a transmitting station that sends the signal, the antenna picks up the signal, and you can, in your house, listen to the radio or see the picture. We, by surgery, put in a receiver which goes around the auditory nerve. There is an antenna which is put under the skin with a little magnet in the center, the magnet being to position the transmitter ring outside. So the computer has a little wire that goes to a transmitter coil, fits onto the skin, the antenna inside picks up the signal. So that electrical information in the computer now goes to the nerve and the person can hear. It has to go to the brain. So you are literally replacing the function of the inner ear. For the first time, one of the special senses has been replaced. And the surgery is only to put a receiver inside. The main work is done by the computer outside. So in a hearing aid, you're only amplifying the sound and still using the patient's inner ear or cochlea. In cochlear implants, you're doing the work of the inner ear outside the body and then sending it to the nerve inside by implanting a receiver. There are no batteries on the inside part. All the power batteries is in the outside computer.
So, doctor, once the cochlear implant is done, does the child start listening immediately?
Well, no. As a matter of fact, surgery is just the beginning. It's like planting a seed. It requires, especially in children, because they're born without language and speech, they require what is called auditory verbal therapy. There is something else called mapping. Mapping is tuning of the implant, which is usually done by audiologists. So, as the healing occurs and the thickness of the scar tissue changes, you may have to do resetting of the map from time to time. So, maybe in the first 1 year, they'll make about 5 or 6 visits to fine tune the implant. That's called mapping. But more important, the child is going to hear just sound. It has no language. So they have to be literally taught how to make use of this incoming sound. So it starts off with recognizing certain sounds, basic sounds, then going on to words, and then to sentences. It's a back-breaking job. Even a child that's born normal with normal hearing takes 2 to 3 years before it can start speaking in sentences. So even if you operate on a child, let's say, who's 2 or 3 years old, it's still going, that was going to be the first time the child has heard proper sound. So it will take that period of 2 to 3 years of training with what are known as special educators or auditory verbal therapists, who will sit down with the child and train the child to make use of the incoming sound, to learn the language and be able to speak. If you don't do this, a cochlear implant would be useless. So cochlear implant is surgery, audiology doing the mapping and tuning of the implant, and the auditory verbal therapist sitting there. And it's a back-breaking job, because sometimes you're operating on children who are 7 and 8 months old, to sit with them and to train them and take them through the next 2 or 3 years. That is going to determine the outcome of the implant. So it's the whole team that matters, not just the surgery. You know, even a normal child going to a normal school, if the parents sit with the child at home and do some homework or schoolwork with the child is going to fare better in school, in general progress. The child goes to the therapy center with the auditory verbal therapist, maybe 2 hours, once or twice a week. The parents or the caregiver, whoever is there with the child, is shown how the therapy is conducted and is literally given homework to do at home with the child. So it sort of reinforces whatever therapy has been given in the center. You know, in COVID, it got very difficult for people to go to the centers. And necessity is the mother of invention. So people started trying to do this therapy online. And today that's become quite the norm, that you do a few face-to-face sessions, but you may not have to come, because traveling in India, in Bombay, is not very easy. And sometimes in the rural areas, they have to travel 50, 60 kilometers to reach the place. And today, almost everybody has a smartphone. So they are able to do a lot of the therapy part online. And now, people are developing techniques and software and hardware to even do the mapping part online with the help of a parent or with a caregiver sitting remotely. So that is what came out of the COVID pandemic. What it translates into is that much less dropouts of sessions is there because, oh, it's raining, I could not go to the center. Today I had some work, there was a train strike, I couldn't go. All that is eliminated because they can still join online. So that has certainly made things easier as far as regular therapy is concerned, what we call auditory verbal therapy, which is an essential part of cochlear implants. So one thing which I did not mention earlier is that these operations are to be done in children who are born deaf and who require the implant as early as possible. A child newborn who is normally hearing will hear everything that you say, but will understand nothing and cannot speak. That area in the brain is blank. Every time the child hears a sound repeatedly, it gets stored. Then meaning is given to it. And then networks open so that the child now say the word mummy. The child after sometimes understand that mummy means this person. When I want to call this person, I need to sort of connect from that memory area of my brain to the muscles that control my voice, my lips, my tongue to produce this sound. So this whole network opens in the earliest years of life, starting with your birth or maybe even a little before birth. Children understand sound and goes on maximally, most favorably in the first 2 years of life. You can stretch it to 3 years or 4 years, but after that, the capacity for this network to open, they are known as synapses, to open up becomes less and less. So the earlier you intervene, whether by hearing aid or by cochlear implant, better the outcome. If you bring an older child who hasn't heard since birth, say a 12-year-old child you bring to me, I can still do a cochlear implant if required, but the child will hear sound, but the capacity to give meaning to this sound and using that sound to open up channels to learn language and speech, that capacity goes down. So it is important that if intervention is needed, whether hearing aid or cochlear implant, it should be done as early as possible. Today we are operating on children at 7 and 8 months of life.
Doctor, coming to adults, can you please share what causes hearing loss and what can be the preventive measures to prevent hearing loss?
Okay. Since we were talking about cochlear implants, can I say something about adults and cochlear implants?
Please.
Cochlear implants were initially devised only for adults.
Oh, really?
And in the early 90s, when people said we'll try it in children, some of the very famous ear surgeons said, oh, it will never work. Today in India, we are doing almost 90 to 95% children and 5% adults because of the funding. But in the developed countries where the government or the insurance pays for the implant, it's almost 50% adults, 50% children, or some cases 60% adults and 40% children. In India alone, I feel this funding issue is, I've talked to several colleagues of mine, all of them have that 90% plus children. But it is really designed, or it was designed originally for adults. Yeah. So let's see what are the common causes of deafness in adults. One is, of course, age. Age-related degenerative changes. And because of various medical advances now, it's not uncommon for me to see an 85-year-old man or even older, close to 90, walking into my clinic, ramrod straight, otherwise quite mentally and physically fit. The only thing is not able to hear. That degenerative changes in the ear have gone so far that even a hearing aid is not really helping him. So these would be candidates for a cochlear implant, provided they are mentally and physically fit. Okay. Injuries to the ear, accidents can produce deafness, infections in the ears. where you have discharge coming, pus coming, etc. from the ear, can in the long run produce a certain amount of deafness. One other cause is noise exposure. So exposure to loud sounds for prolonged periods. People who are working at the factories without adequate protection, airlines. We say that if you measure the intensity of sound, if you have a 80 decibel sound you're exposed to in your work environment for 8 hours a day, then over a period of years you will definitely have a hearing loss. If that level goes up to about 100 decibels, then even shorter exposure can lead to deafness. And if you have a very loud sound like 130 decibels, if you're standing very close to an aircraft or a gunshot sound very close to your ear, or we've had patients who've suddenly lost hearing with a single exposure to a sound of 130 decibels or more. So hearing loss due to sound exposure is another cause. One other cause is ototoxicity. Tuberculosis in India is quite common, and formerly we had to give them streptomycin injections. So that group of drugs can produce damage to the inner ear. So, and there are degenerative conditions which also lead to degeneration in the inner ear. So these are the people who come to us saying that hearing aids are not helping. And we do a very simple test for them. We make them put on the hearing aid. And audiometry is where you test a person's hearing by giving them tones. And they have to put up their hand to say, okay, I can hear it. So you keep on increasing the loudness till they can hear a tone, and you plot an audiogram. So instead of giving them tones, you give them a hearing aid and give them words or sentences with a properly fitted hearing aid and see what % of the words they can catch. And if that is less than 60%, which means the hearing aid is not helping them more than that 50-60%, then you could consider them for a cochlear implant. They will also require some amount, the mapping will of course be required, tuning of the implant, but they will also require some amount of auditory verbal therapy, but it is much less than what is required in children because they already have language and speech. Over the past 2 or 3 years now, I see more and more acceptance of this, and I'm doing more and more adults now than I was doing, say, 5 or 10 years ago. And I think the major factor holding them back could have been the expense, because the cost of the implant is about 6 lakhs. So everything together and hospitalization comes to about 7.5 to 8 lakhs. And very often when I explained all this to the patient, they would say, oh, we'll think about it and come back. But people have realized that your quality of life is getting impacted, and therefore more and more people are now getting it done. So we always give them a hearing aid trial, test them with a hearing aid, and if found inadequate, we would advise them a cochlear implant.
Doctor, how readily do people accept a hearing aid or a cochlear implant?
It's a question of, I think, vanity. I don't know, or false vanity, I would say. I have patients to whom I have advised a hearing aid, and the first thing is, oh, no, doctor, not a hearing aid. Nothing should be seen outside. They're happy to wear glasses. They're happy to wear dentures. They're happy to walk with a stick. But they don't want this to be seen. I have an 85-year-old who says, oh, doctor, it will make me look old. So, I really don't understand this hesitancy to wear. Helen Keller, who was, both deaf and blind, when she was asked which of the two is worse, she said, no, deafness is worse than blindness, because blindness separates me from things. Deafness separates me from people. So, in spite of this, people don't want to wear this outside. They want something invisible. And again, when I tell them about cochlear implant, the first question is, oh, but doctor, will something be seen outside? And, I was under the impression that I have a very strong argument and I can convince them. So I would ask them, if your best friend turned up tomorrow wearing a hearing aid, would your attitude be different towards your friend? And they say, no, of course not. So which means you're the only good person in the world and everybody else would look at you differently.
Right.
And I thought this would be a very strong argument, but believe me, it doesn't work. So I think somewhere we have to remove this stigma that, oh, it should not be seen. If you can wear glasses, I don't see why you can't wear a hearing aid, because believe me, it impacts their quality of life. Adults who can't hear, in the family discussions going on, tend to withdraw. They become depressed. They become paranoid. If somebody laughs, they're wondering, are they laughing at me? They don't want to meet people. It's really bad. And this will hasten dementia. If the patient is going to develop dementia, if you take away this input. So it has been shown that in very early dementia and deafness, if you give a hearing aid or a cochlear implant, you can actually arrest or even, that dementia can be slowed down or arrested in the early stages. But people don't seem to realize this just because they don't want it to be seen outside.
Doctor, you've been traveling a lot to mentor surgeons in their own hospitals during their early surgeries, right? So, why is mentoring so important to you, and how does it help? What's the kind of, the quality of care that improves, especially in rural areas? Can you please share any such?
Yeah, most certainly. I told you that we are using an implant which is very expensive, a cochlear implant. I mean, I mentored mainly for cochlear implants. The lowest cost implant is about 6 lakhs. Now, the people who come and train with me, my fellows, so my commitment is that it's not only you take training with me and go away, but I'm going to help them establish their program so that the people in that area don't have to travel now to major cities for treatment. So right now I've got a fellow from Calcutta. Before that I had somebody from Tripura, from Assam, also from Kerala. I had somebody from Nepal, even Bangladesh. These are all accomplished surgeons. They are not novices, but they haven't done implant surgery before. They come and train with me, they see surgeries, they get a little hands-on. We have training models on which we train them. And by the time they go back, they know all the steps. But surgery is not mathematics. Every time there is a little variation, and they have their anxiety that when they do their first operation, will everything go smoothly? And they know they're handling something worth 6 lakhs. That implant, what goes into the inner ear, is less than at times 0.5 millimeters. It's like a thin hair going, and if you bend it or if you damage it, you just have to throw away the implant. I mean, it's gone. So that is the anxiety that they have, and sometimes they are not sure whether they're going to encounter a situation which they may not be able to overcome. It's like, when you do something with your own hands a few times, then you get the confidence of going ahead and doing it. That initial anxiety or fear is what we need to overcome, and that's why the mentoring. So that's my commitment to them, that wherever they may be, as I said, or Tripura or Assam or any other corner of the country, including Bangladesh and Nepal, when they do their first case or first few cases, I travel there. Initially, I may actually wash up with them and be assisting them. Maybe on the next visit, I would say, okay, I'm just standing in the operation theatre. And within 2 to 3 visits, usually most of them, I mean, there have been some who I just had to do one visit and I said, okay, they're so good, they're managing. There are some who require maybe 6 or 7 visits. But most of them within 2 or 3 visits are able to manage.
Just
so
you being around must be.
Yeah, it's a confidence level that,
booster.
in case I can't manage, there is somebody there. Now, of course, what happens is they can connect to me sometimes when they are operating and they have a difficult situation. They'll phone me up on a video call. There's a camera attached to the microscope they're operating, so they're actually able to show me where they are stuck. And there have been occasions where I have suggested to them a solution, they have implemented that, and have completed these surgeries. So it's basically a confidence boosting thing for them, but also for the patient it is important that somebody is performing his first operation and there is somebody experienced standing behind him to make sure that everything goes well. Because it's not just a matter of training, the idea is he should be able to establish his own center, and I have managed to do this in almost all parts of the country, even in other countries like Bangladesh. So that's why traveling is necessary and it takes up quite a few weekends.
Doctor, you've conducted many free surgical camps in rural areas. So, can you share a story of a family or surgeons, who have deeply been impacted by this kind of work?
Surgical camps that we did, this, as I said, was in the late 70s and the 1980s. There were a lot of areas in tier 2, tier 3 cities and rural areas in India where microsurgery of the year for restoring hearing was not being practiced. So people from there had to travel to major cities to get it done. And as I told you, we were conducting workshops teaching this at KEM. So the surgeons who came there then invited us, saying that in our area there is no awareness that such surgery is possible. So can you all come? We'll set up a camp, we'll get patients together. So we've done this in Maharashtra, in Gujarat, in Rajasthan, in Karnataka. We have done it in Bengal, Assam, variety of places, Andhra Pradesh. In those areas where this was not being done, and the local surgeons invited us to do it. What it did was, we would carry with us not only our operating equipment, microscope, but we would put cameras on. So the local ENT surgeons who were interested could come and watch what is going. And they got the confidence now after watching to do it. Give you an example, we went to one place and the first time we went there, they had never seen microsurgery, most of them. So everything that we did was appreciated. Oh, fantastic, this is superb. 5 years later, we went to the same place. And this time when we were operating, there was no appreciation but only questions. That when I do this step, this is the difficulty I have. Sometimes I have encountered a problem. So what it told us is that what was 5 years ago changed so much because they got access. This was before the days of internet and YouTube. So they had no access to this. Once they got access, it spread. So, and therefore the population in that area now no longer had to travel and got the services in-house. So today all over India this would be done without a problem. After the 90s there was no more need to go ahead and do this because information was much more easily available. But so it was mainly in the late 70s and mid 80s that we did this. As a matter of fact, I was in Africa. I used to go there every year for 20 years, 1987 to 2007, I think. I went every year and I would operate at the hospitals in Nairobi mainly on children who had a deafness problem. And sometimes we would then afterwards go to Masai Mara for a safari. And in the latter part, when I was sitting at one of the safari lodges, this young waitress comes to me and says, "Are you Dr. Kirtane?" I said, "Yes." And he says, "Don't have your dinner here. We are taking you into the jungle for a very special dinner." And I said, "Why? What have I done?" So she said, "No, that a young boy that you had operated on was able to now here go to school and he's become a chef here and he recognized you. So he wants to give you this treat." So like him, there are many, many students or children or even adults who after getting their hearing back got the confidence to go out and get a job, work, make a difference in their earning their livelihood. So I think, and there is a cascading effect because what you taught some people then went on to more people and a lot of patients got benefited with that. Yeah.
Brilliant. Doctor, you have conducted 4,000 plus cochlear implants in your entire practice. And cochlear implant surgeries we know can be very expensive. So especially for families from weaker backgrounds, are there any schemes, to help out? Does the government do anything to subsidize the cost? I know that, you specially set up a foundation. Can you please share about the I Hear Foundation also?
Okay, so let me first say that it's not the surgery that is expensive, it's the implant that is expensive.
Right.
The surgery
device
is,
itself,
is,
yeah.
is like any other ear surgery, but the devices are imported. So the minimum cost is around 6 lakhs, a little plus 6 lakhs plus. And since it comes from abroad, there is no way we can do anything about it. So that has been a big deterrent, as you very rightly said. I run a free OPD at the Hinduja Hospital every Tuesday afternoon for the last 20 years. It's a completely free OPD. And almost 9 out of 10 patients who come there come from a background where economically they may not be in a position to spend that kind of money, 7.5 lakh rupees. As you rightly mentioned, there are government schemes. There is a ADIP scheme from the central government, the RBSK scheme, where patients have to go through a certain channel, put up all their data, and they can get the implant free of cost. And some of the states have also put up schemes where you can get an implant from being funded by the state. We started a foundation, it's called the Iyer Foundation. This foundation was started by us in 2013. There was a foundation existing which was about to close down, so we took that over. So it's now 11 years, and we collect donations from people who are able to give us the donations and then use it for doing cochlear implants. This concept really came of getting donations in 2003 when my first donors were Mahindra and Mahindra, and they donated us 60 cochlear implants to celebrate 60 years of Mahindra and Mahindra. Wow. More recently, because of the corporate social responsibility, many companies are coming forward to donate to causes which they feel are worthwhile. So we get donations from various trusts or various organizations, and through this, which sort of the donation comes into Iyer Foundation, through that we fund cochlear implants. Most of these are given for children, and that is why, as we mentioned earlier, we have more than 90% children and 10% or less than 10% adults, because the adults don't get funding. In many Western countries where funding comes from governments or from insurance, there is 50-50 or even 60% adults and 40% children. Of course, one has to realize that there is some amount of expense even after the operation. There is batteries which need to be changed. These are kids who might be, doing a little bit of physical activity where a wire might break and that has to be replaced. Visits to the therapy center, travel, paying the fees of the therapy center, training center. So these are costs which also need to be factored in. And some of the government's programs take care of that for the next 1 year or 2 years, but the expense is almost lifelong. And then comes what is called upgrade. What I've operated 10 years back, the outside processor now is outdated. The company no longer manufactures, it cannot be repaired. So these patients now who took the benefit of donations are suddenly faced with a problem, this can't be repaired, I need to buy a new one. So we are also, through the Iyer Foundation, funding some of this. Our funding works in such a way that we pay a large amount, but the patient is expected to pay a small amount, so that they have a stake in the whole thing, and they value it more and they don't become what we call non-users. So this problem definitely exists, and you were very right in asking that question about how do they afford it. But government programs and private trusts like the one that I have, Iyer Foundation, are looking into that. But I think we are only scratching the surface. There's a big, large population of children out there, and I think the first thing that is required is awareness, 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 that even a normal looking child could have deafness. A child falling behind in school, poor child is getting, labeled as a dull student or a dunce, is actually suffering because it can't hear. I mean, the awareness that something is now available to correct this, check it, get it diagnosed, and can be corrected. That awareness is step number one if we are to address the problem all over the country. I think we are scratching the surface. Maybe 5% of the children who really require it are getting treated here.
Doctor, are there any specific disabilities that which are accompanied by hearing loss? What are the tests usually conducted to ascertain the same?
Uh, Many of the children that we get uh, may have some associated problems as well. And that does not mean that if they are candidates for cochlear implants, it cannot be done. It doesn't mean that. It depends upon what is the disability and the extent of the disability. There are syndromic children with multiple problems who can be operated, provided the other problems can be reasonably well tackled. You could have children with heart problems, kidney problems, which the specialists in those areas would say, okay, we can take care of this, you can go ahead and do the implant. You have some children with attention deficit and hyperactivity. We have operated on them. We've had children with autistic features, but provided they are not very severe, we would consult a pediatric neurologist who also has a psychologist working with them, and they would say, okay, we think this child would be able to manage, because it's not the surgery, but the post-operative training is where we would require that cooperation. We've had children with, say, Downs, where also we have operated because they were quite okay as far as cooperation was concerned for doing the treatment. We've had some children with visual problems, children with cerebral palsy, for example. The problem with cerebral palsy again is that they have to be able to sit and take the therapy, but we have operated on these after consultation with the concerned specialist. So we would talk to the pediatrician, the pediatric neurologist, the psychologist, at times with the physiotherapist, occupational therapist. So they all form a part of our team. And if these experts feel that the child with whatever disability that it has is capable of going ahead with the surgery, physically fit, and also capable of cooperating subsequently in the therapy that is required, we would still consider the child for. So the diagnosis is not really made by us, but when we suspect something is wrong, it goes to the pediatrician, to the pediatric neurologist. So they would come into the picture and they would diagnose, gauge the extent of the disability and advise us on whether we can or should go ahead or not.
To some families, when they are asked to do a BERA, a simple test, can you please explain about the BERA? Why does a pediatrician ask a family to do a BERA, and what is it? What does it lead to?
BERA stands for brainstem evoked auditory responses. Whenever we hear a sound, as I said, there is an electrical signal created which goes. So the BERA allows us to measure this electrical signal from the brainstem. Now, if you get a signal from there, it means that the ear is working. If you get the signal but it is weak, then it tells you that the ear is working, but so you are able to quantify the amount of deafness. In adults, when we do hearing testing, we give a sound and the adult is supposed to say, I can hear or I don't hear. So it's very simple. But in a child who's 6 months old or 3 months old, the child is not going to be able to respond. So BERA becomes one of the tests by which we can determine, is there a hearing problem and what is the extent of the hearing problem as far as the ear is concerned. For doing the BERA, we need a quiet child. So some amount of sedation needs to be given to the child. But you don't have to poke any needles. It's oral sedation that you give and the child goes off to sleep and the computer does the test. The sound is given. It doesn't require the child's cooperation. The responses are picked up, and looking at the wave pattern, you know at what level the child is hearing sound. So there is nothing to worry about going for a BERA test. Yeah.
Doctor, what steps do you believe that healthcare professionals and policymakers both can take to create a much more inclusive environment for children with disabilities, both in healthcare settings and in society at large?
I think this problem is huge. There are a number of children going undiagnosed. There are a number of adults who don't even know that there is access to treatment for what problem they have. So I think the first major step, with the help of media, whether it's print media or whether it's the electronic media, is to have programs to spread awareness that deafness can affect your lives. It is correctable and it is available. The correcting facilities are available. The second step, of course, would be to then put that into action and make these facilities available. You know, we talked about universal newborn screening some time back, that there should be a law that says every child should be screened. But you have a lot of public hospitals where patients come, say, even to Bombay from surrounding areas. Now, it is not sufficient to tell the mother your child is not hearing. What is the next step? Access to hearing aid, that costs money. The hearing aid user has to then sit with a specialist or educator to make use of that hearing aid. So that facility should be available. That person should be capable of not only training the child, but making a decision, oh, this is not enough, the child requires a cochlear implant. The cochlear implant comes at the top of the pyramid. But awareness, diagnosis, counseling, hearing aid, training with hearing aid, integrating them into an institution where this can go on, because the child not only has to be treated for the hearing loss, but has to start going to school. We have got a lot of children who've been operated for cochlear implants who, within 2 to 3 years, we've been able to integrate them into normal schools. And somewhere along the way, the public conception, about hearing aids, that has to change, because it saddens me to say that in our society, the blind receive sympathy, which is absolutely okay, but the deaf often receive ridicule. You'll hear jokes being made about, even in the movies, about somebody who can't hear properly and there is misunderstanding. Nobody makes jokes about blindness, but as I mentioned to you in the words of Helen Keller, deafness is worse because it separates you from people. So how do we inculcate into the psyche of the people that, look, these people who are suffering, it's an invisible handicap. You can't see it, but that doesn't mean that they should be ridiculed. They require as much support as other handicaps do. I think that how to get it into through schools or how to get that in is something which is extremely important. The whole attitude towards deafness has to change. Facilities have to be made available. Hearing aids are expensive. So, indigenization, manufacturing in India at a level where hearing aids become affordable. Institutions and trained people available to teach people how to make use of the hearing aid. Cochlear implant is the last in the ladder. So, I think these are issues that need to be addressed. But I think the most important is information and the attitude change towards deafness. How to bring about that, I really don't know.
No, it's great that you spelled it out. I'm sure a lot of people who are listening to this, will also agree to what you're saying, and it's much more important coming from you. When it comes, hopefully there'll be a movement.
A child in school is not able to hear properly, is falling behind in studies, is labeled as a dull student. Unfortunately, that child doesn't even know that the other children are hearing better than him. He feels everybody is like him. So he doesn't understand why he's being labeled.
In fact, his whole confidence gets shaken that, something wrong with me.
No, but he doesn't even know that the others are hearing better. He can't complain saying, I can't hear, that's why I'm falling behind. Right. And that is why that testing is important. I've seen this with my patients, cochlear implants done. I've got a girl who stood first in the 12th standard in a normal school with one cochlear implant. Wow. Today, she's doing a job in a bank in Denmark. So she's not only learned Marathi, her native tongue, English, she's also learned Danish, and she's working in a bank. December, she's coming to get married.
Lovely.
So, if you give them that capacity to hear, But for that, you have to accept that it's a handicap, and what they need is support, not ridicule. That psyche of the society has to change.
Thank you so much, doctor. Thank you so much for your time. And such beautifully, simply आपने सब कुछ समझाया. I'm sure सारे जो सुनने वाले हैं सबको बहुत important है ये message और बहुत सीख मिलेगी. Thanks a ton for doing this with all of us.
Okay.
Thank you very much.